So this is, once again, starting with a scenery photograph. This is one of the lakes along the chain of lakes, which is between Libby and Kalispell, Montana, in the northwest corner. We're going to talk about gallbladder disease. The two websites are where Dr. Hughes and I have questions for the USMLE that you can use. My two Twitter sites. I haven't been active for a while, but I keep saying I plan to get back in. I probably will try here and post these lectures. And like I said, I'm a forensic pathologist, but I have a general interest in general pathology and organ pathology. I really like natural disease. And so I have a more superficial knowledge of everything over a broad spectrum, and I hope that helps me teach medical students better. So pause the slide, read my disclaimers, make sure they do not apply to you. If they do apply to you, then don't watch the lectures. Same thing, read it. If the disclaimer applies to you, then don't watch the lecture. And then, like I said, if you want to know about my teaching style, it's on the introduction presentation. These are the references, all excellent books. I actually have 4 questions. So once again, with each question, pause, look at it, see if you can answer it. The idea being that you haven't had this material before. Probably a lot of you have. But anyway, it helps you focus as you go through the lecture and increases retention time. So there's the first question. There's the second question. Third question. And fourth question. So when you're talking about gallbladder disease, kind of like with the pancreas, is rather limited topics. There's essentially really gallstones and cancer. But the gallstones can have a wide range of effects, and there's different types, and they're very important to discuss. So cholelithiasis are basically gallstones, gallbladder calculi. They're usually cholesterol, which is made of cholesterol monohydrate, or pigment, which is bilirubin. The mechanism for cholesterol stones is supersaturation of the bile with cholesterol. And then the mechanism of pigment stones is precipitation, or I guess kind of supersaturation, with bilirubin, calcium salts, and then following overproduction. So one way that you can produce too much bilirubin is with unconjugated bilirubin. When you break down a lot of red blood cells, you produce a lot of hemoglobin. That breaks down to bilirubin. That can be a high level of it. So people who have like a hemolytic episode with G6PD deficiency or things like that will have potential for forming pigment stones because they'll basically be producing too much bilirubin. Risk factors: increasing age, females, ancestry as well. Certain ancestral groups have a higher risk for gallstones. And then for cholesterol, especially obesity, multiple children. So they always talk about the 4 Fs: females, fertile, over the age of 40, and then obesity. So this shows the 2 types, cholesterol gallstones. And actually, we see a range of colors and everything like that. I mean, I've seen some that actually look like crystal. It's amazing. But the 2 main ones are cholesterol and pigment. So cholesterol gallstones are at the top left. They're usually kind of yellow-green in color. Variable shapes, sometimes multifaceted in that. And then pigment stones, it seems like tend to be smaller. They're more black. So pigment stones, actually, they're firm and they really don't crush very easily. Whereas with cholesterol stones, at the top left are cholesterol stones. The bottom right, you see that brown stuff in the center? That's where I've actually broken them. So with a cholesterol stone, you can actually take it between your fingers and crush it. Whereas with pigment stones, they're more solid. There's more to them. I mean, you could crush them if you really wanted to, but the cholesterol stones crush pretty easy. So complications of gallstones, they can obstruct the bile duct. So first of all, I mean, they're sitting in the gallbladder. And so that by itself can generate some degree of inflammation. The most common diagnosis when we saw a gallbladder during residency was chronic cholecystitis. Now, actually, I always thought that stones in the gallbladder, when the gallbladder compressed to squeeze out the bile to help absorb the fat, would cause pain, but it doesn't. It's when they get out into the duct. So actually, stones in the gallbladder are pretty much asymptomatic, but still there's stones in the gallbladder, and so they're going to trigger some background inflammation that can lead to a chronic cholecystitis. If the stones get out and obstruct the bile duct, that can lead to an acute cholecystitis. And then also if it gets in, that's in the cystic duct, if it gets into the common bile duct, it can block the flow of bile and affect the liver, so you can get jaundice, elevated liver enzymes, and that. Okay? So then the other thing too is that when you have a stone in the duct, it could cause perforation or, I guess, potentially in the gallbladder itself. You can get a fistula. Once you get a stone in the bladder, you get inflammation. It's possible to get a connection between the cystic duct and the duodenum, and then the gallstones can pass there into the small intestine and cause an obstruction. And then obviously we talked about, well, if you're not to lecture, acute pancreatitis. Two main causes of acute pancreatitis, one of them is gallstones. So as you look here, you can see some really large yellow stones and some small ones. The small ones are actually the more concerning ones, because those are the ones that are more likely to get into the cystic duct and then the common bile duct. And the pain is right upper quadrant. They're going to have it after they have a meal, because that's when the gallbladder is compressing and moving it out. And then it'll be a crampy pain. One thing I've learned, when you have crampy pain, it usually means that you have something in a tube. So in the small intestine, in the ureter, or in the cystic duct or common bile duct. So this was a person with a fistula that developed between their duodenum, which has been opened, and where you see the black arrow, that's the fistula opening into the duodenum, and then between that and their biliary tract system. Since we're talking about it, I'll just mention this also. This is cholesterolosis. What you see is, you see little fine yellow stippled discolorations of the gallbladder mucosa. And then microscopically, the yellow arrow shows, and there's a whole bunch around, you see foamy macrophages. This is from an autopsy. We obviously get terrible histology with gallbladder at autopsy, because the bile in it breaks everything down. But this actually, I've been told, is a reason for doing a cholecystectomy. So this is actually a Horseshoe Lake. This is along the chain of lakes. You can see a little island out there. They actually filmed a really low-grade B horror movie on that called On Heaven's Pond. One of my dad had a friend who helped build the home they used, the cabin they used on the island and stuff like that. So if you ever want to watch a really low-grade B horror movie, On Heaven's Pond, and this is where it was filmed. Okay, so we'll talk about cholecystitis, so inflammation of the gallbladder. You can have acute calculus cholecystitis, so this is where you have obstruction of the gallbladder at the gallbladder neck, and I'll show you something like that, or within the cystic duct. And so if the obstruction stays long enough, usually about 4 to 6 hours or greater, then you can get inflammation. And acute calculus cholecystitis doesn't sound like much, but it is. You can actually die from this. It could actually lead to sepsis. Acute acalculous cholecystitis is inflammation of the gallbladder, but there's no stone. This usually just occurs in patients who are very ill, those who are potentially terminal, are very ill, have multiple comorbidities in the hospital. And then chronic cholecystitis can be calculus or acalculous. And like I said, what happens is basically when you have the stones in the gallbladder, they're going to be asymptomatic, but you still have stones in the gallbladder, which can lead to some low level of inflammation. And over time, that can cause basically a person to have chronic cholecystitis. So what we'll see is usually a wider gallbladder, thicker wall will be fibrotic in that. So at the top left is acute cholecystitis, which was acute calculus cholecystitis. It was due to a gallstone. And you can see the gallbladder is discolored. So for comparison, I put a normal gallbladder at top right, and at the bottom was what the mucosa looks like. It's just all hemorrhagic, inflammation, very sick. And like I said, this can lead to sepsis and can lead to death. Chronic cholecystitis, the wall will be more thickened, more fibrotic. The bottom right shows that. You can see the fibrosis, and then what will happen is the mucosa will basically dip down into the underlying muscularis, what are called Rokitansky-Aschoff sinuses. And for comparison, I put a normal gallbladder to the left. This one actually had a gallstone at the outlet of the gallbladder, but apparently, bile was able to actually get around it, or it was just displaced there right before their time of death or anything like that. I don't think it was artifact, and I definitely didn't place it there. So carcinoma of the gallbladder, cholelithiasis, once again, you can look along the lines of cholelithiasis, stones in the gallbladder are going to set up some low-level inflammation. Anytime you have low-level inflammation, you get cell death, you get proliferation. Anytime you have proliferation, chance for mutation, chance for dysplasia, neoplasia. Usually it's found females greater than males. This will probably go along with the fact that cholelithiasis is more common in females than males. Usually elderly individuals, 7th decade. And about 95% are adenocarcinoma, so by far it's most common. So right upper quadrant, you can get right upper quadrant abdominal pain, jaundice. I would assume is due to potential extension and blockage of the common bile duct. nausea and vomiting, and anorexia. So this just shows adenocarcinoma. You can see the glandular differentiation down at the bottom. A lot of areas do look pretty solid, but you can see some glands in there. But this was adenocarcinoma of the gallbladder. So first question. So pause, answer it, and then we'll go through it. So 42-year-old female is involved in a motor vehicle accident and dies at the time of impact from blunt force injuries. An autopsy is performed, which reveals a few 0.8 centimeter multifaceted pale yellow-green stones in the lumen of the gallbladder. Of the following, which description most likely matches her ante-mortem clinical history related to the autopsy finding? So purely related to the autopsy finding, stones in the gallbladder do not cause abdominal pain. That biliary colic occurs when it gets out into the duct. And there's not one in the duct, so she shouldn't have that. So she would be asymptomatic if her symptoms are representative of her pathologic finding. Second question. So pause, read it, and then we'll go through it. So a 43-year-old obese female is brought to the emergency room by her husband. He reports that she is having severe abdominal pain, which began about 6 hours ago, sometimes shortly after they had dinner. The pain is intense and incapacitating. He also indicates that she has been nauseous and vomited several times since the pain began. An ultrasound performed and a diagnosis made. Of the following choices, which would be the most likely cause of her symptom? So with this, basically the decision is between cholesterol and what makes up the stone. So the most common stones are going to be cholesterol. The unconjugated biliary would be possible, but there's nothing in her history that would represent that. So there's no hemolysis or anything like that. And a 43-year-old obese female right there, it's most likely to be cholesterol. And then a large stone is more likely to stay in the gallbladder and usually will not be symptomatic unless it somehow became wedged in the outlet. But a smaller stone could easily get out in there and do that. So the answer I was looking for is that, the first one. A calculus made of predominantly cholesterol because that's most common, and especially given the history, and then small so it can get out into the duct and cause biliary colic. Third question. Once again, pause and we'll go through it. A 52-year-old female is brought to the emergency room by her husband. For the last 12 hours, she has had severe unremitting abdominal pain in the upper gastric region, which radiates to her back. Her husband says that she has been essentially unable to move because of the pain and has been nauseous and vomited several times. The pain developed about 2 hours after they finished dinner. She has had similar pain before, but nothing this severe or long-lasting. Her vital signs are temperature of 99.6 degrees Fahrenheit, heart rate of 103 beats per minute, and blood pressure of 121/80. Physical examination reveals tenderness of the right upper quadrant. With the inspiration, the pain worsens and the patient stops inspiration, which is associated with biliary colic. Of the following was the most likely diagnosis. So one possibility also is acute pancreatitis because it's in the epigastric region and it radiates to the back. And then pancreatitis obviously can come from gallstones, so maybe that's what this is, but it's not a choice, and that's probably why I didn't include it there. So what this is likely acute calculus cholecystitis. It's been pain that's been going on for a period of time, which would allow cholecystitis to happen. Usually it's about greater than 4 to 6 hours. If the stone moves through before that, they are not usually going to get acute calculus cholecystitis. But if it takes longer than 4 to 6 hours for the stone to move through the cystic duct, that's when they're at risk for it. And this was 12 hours. Last question. So a pathologist performing an autopsy on a 58-year-old male who was found dead in his bed during a welfare check by police, which had been initiated by a family who lived out of state. The peritoneal cavity had fibrinous adhesions, focal hemorrhage, and a large amount of cloudy yellow tan fluid, so peritonitis. The proximal segment of the small intestine is dilated, and the serosal surface has friable tan material on the surface. In the lumen of the small intestine, the distal end of the dilated segment was a multifaceted yellow-green firm but easily crushable stone. Of the following, whether pathologic finding should the pathologist discover? So the stone got into the small intestine. That would mean there has to be a fistula. Okay, so once again, use reflection. Think about the lecture. Think of what are 5 important points that I made. Or, like I said, I hope I made 5 important points. And this is a really great technique. Like I said, Make It Stick talks about a medical student. Bottom of class, top of class, using this one technique. So I highly recommend it. I don't have a summary slide because of that. This, I think, is the same lake. You can see the same view down there. I believe we were on a road to one of my mom's friends' houses, and I took some of these pictures and that. So I was very fortunate. Grew up in a very beautiful part of Montana, a beautiful part of the country, and that. I hope the lecture was useful to you, and thank you.